Once a patient responds to frontline treatment, and generally that's a complete response, patients are monitored. They're monitored for toxicities, generally that's neuropathy, their hair grows back, and they're also monitored for disease recurrence. And I get it that there's a lot of controversy how those patients should be monitored. And you basically got three options. Symptomatic, examine her, and that includes a pelvic exam, and talk to her. Or you can do radiologic imaging, CAT scan or PET scan, or you can do CA-125. And I think I have a pretty good handle of what we do in the United States, and most people, believe it or not, do CA-125. That doesn't mean that if the CA-125 goes up, that they begin treatment, okay? What it means is that they use the CA-125 maybe every 3 months or so, and if the CA-125 begins to rise, then they do a CAT scan or a PET scan, and then they integrate the symptoms, which are important, the rate of rise of the CA-125, and the radiologic findings to make a decision. The reason the controversy about CA-125 exists is because people think that when it goes up, you have to treat. No. We use the CA-125 as a trigger, as a triage, to order imaging. It's okay and certainly acceptable if you don't want to do imaging ever, and you don't want to do CA-125 and focus on symptoms. But in today's world where we have many therapies, for that patient that develops a recurrence, many individuals and patients want to know early if their cancer is recurring. And in this particular patient, CA-125 is a marker, and it can be monitored. And this particular patient recurred more than 2 years after initial treatment, which is a little longer than what you would expect. And why? Because she had a BRCA mutation. BRCA mutations have a longer time to progression. So for this particular patient, more than 2 years of time to recurrence is pretty common. And so she would then be evaluated, sometimes considered for secondary debulking surgery. Again, that's not evidence-based, but I get it. Given the long treatment-free interval, if there was an isolated recurrence, maybe some would say she should have another operation. Most wouldn't. And particularly if you monitor her closely, the amount of disease that she would have when she recurs is small. So she would be evaluated for treatment, and this would be called a platinum-sensitive relapse. It recurred more than 6 months, and that would be our threshold. So when we see a patient with ovarian cancer, we look at 4 things. The cell type. This is a high-grade serous tumor. The platinum-free interval, it's more than 2 years. The molecular signature, BRCA, she's a germline BRCA mutation, and the number of lines of therapy. And if you wanted to add a 5th thing, it would be existing toxicities. So she would be evaluated for retreatment, and she would be treated with a platinum doublet, generally 3 choices. Carboplatin paclitaxel again, carboplatin gemcitabine, or carboplatin pegylated liposomal doxorubicin, but platinum doublet. Carboplatin always, and either paclitaxel, gemcitabine, or PLD. So you'd have to make that decision, and then you'd have to make the decision whether or not she should have bevacizumab. In December of 2016, bevacizumab was FDA approved for treating platinum-sensitive relapse just like this patient. And it's obviously acceptable to do various things, but most would treat this patient now at the setting of platinum-sensitive relapse with carboplatin, a second medication, and bevacizumab. And there are actually 2 chemotherapy backbones that are FDA approved in platinum-sensitive relapse. Carboplatin gemcitabine and bevacizumab, which had a progression-free survival advantage of around 4 months, or carboplatin paclitaxel again with bevacizumab, which has a 5-month improvement in overall survival based on GOG 213. I invite you to read that. Robert Coleman, published in Lancet Oncology in 2017. And so that's what this patient had. Carboplatin paclitaxel, because she could have paclitaxel again, she didn't have existing neuropathy. The treating physician was persuaded by the survival advantage of 5 months with carboplatin paclitaxel bevacizumab and bevacizumab in maintenance. Now the median, and it's treated till progression. Frontline, it's 15 months, but in sensitive relapse, when used, it's till progression, and the median time to progression is 14 months. And indeed, she did just over that.